Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Wendy Hunter. She's a pediatrician. Her Kevin MD article, which we'll talk about today, is titled How a Teenager with Seizures Became the Face of Trauma-Informed Care. Wendy, welcome to the show.
Hi, thanks, Kevin.
So we'll get into your article in a little bit. First off, briefly share your story and journey.
After pediatrics residency, I worked in an emergency department at a children's hospital, and I was a primary care pediatrician there. And so I was exposed to things that primary care doctors don't always see. But because I was primary care in the ER, I saw all the kids that came in for non-emergent conditions. And that's where I started my journey to realize that patients need more than we can give them. We have to go to them. They come to the ER because they don't have transportation, to get to the primary care. And so I started an outreach program where I brought pediatricians into homeless shelters to do health education. And now I'm in primary care myself, and I can still see those hidden kids. And that's what started me.
So you mentioned that in the emergency department, you saw things that pediatricians in the office-based setting may not see. So what would be some examples of that?
Oftentimes I would see really advanced cases of really basic conditions. So like the worst eczema, that just was never treated. So something really basic that it got to an advanced stage where you were getting infections, things that could have been prevented.
So tell me how you work in the ER. How does that influence you now that you're in more of an office-based clinical setting as a pediatrician?
Yeah, I realized there are a lot of hidden kids out there, kids who are not going to school. They'll claim to the school district that they're homeschooled, but really they just aren't going
Mm.
because their parents can't get them. They don't have the resources to get there. I have seen kids who, if you go over a diet history on a kid with obesity, you realize you don't have access to fruits and vegetables. You only have the corner store. And of course, you're going to eat frozen pizza every day because that's less expensive. So those are the kinds of things I saw in the patients in the emergency department who were there for low acuity problems.
So what's your practice like now? Take us through a typical day.
So what's funny is that I am in a really wealthy neighborhood now. So I am part of probably close to the largest. I think we're the second largest single specialty group in the country. So it's called Children's Primary Care Medical Group. We're based in San Diego and Riverside counties in Southern California. And we have 160 pediatricians in our group. And we have like 24 or 26 offices now. So I'm part of that group, and I'm in one of our wealthier neighborhoods. We all do take public insurance. So we take Medi-Cal, which I think really makes us stand out. And the other thing about our group is that we treat behavioral health conditions. So it's pretty uncommon to find a group like this where we treat anxiety, depression, ADHD in-house. And so that's partly what attracts some of our patients to us. And that's why I wrote the article, is that it involved one of those patients.
All right, so let's talk about that article. It's titled How a Teenager with Seizures Became the Face of Trauma-Informed Care. So tell us the story. How did your article come together?
So I know that it's really important to have anecdotes. As doctors, if we're going to get attention for things, we need anecdotes. And I really appreciate the Kevin MD platform because it allows me to tell a story on there where I can then share it with other people, and it has more gravity. If I share it with my organization, it has more gravity than if I tell you this story in an email. So this is how the story went. And this is an incident that happened in my clinic, which, as I said, is in a well-to-do neighborhood. So one of our neighboring offices, the dental hygienist, happened to walk by the front door of our office and saw a teenager having a seizure on a bench right outside our office door. So she came in and she said, "There's a teenager out here. Does she belong to this clinic?" And so I went outside and we couldn't find anybody. And then I talked to our front desk person, and he said, "There's a mom back in the clinic room. She's been coming in and out the front door maybe 5 times. I think she might be the mom." So I went and found her. And in fact, she was the mother. And she was in our clinic with her son. And she had been bringing her son to us for about 6 months for behavioral health treatment. And she knew if she missed an appointment, she wasn't going to get his refills. And so she was very diligent about her follow-up. So we never knew she had a daughter. She had just gotten insurance for her son. She didn't have insurance for her daughter. And it turns out they were homeless. Mom was living in a tent. The kids were living with their father part-time. And the daughter had had seizures for about a year. So this is what the mother's telling us as we're standing there watching the daughter seize. Mom tells us she's been having seizures for a year. She doesn't have insurance. I have figured out that if she doesn't run, she doesn't have a seizure. So I never make her run or exert herself. So why did she have a seizure that day? Well, they had been on the bus on their way to our clinic, and mom realized they were going to be a little bit late.
Hmm.
So she called our office and said, "We're going to be 15 minutes late." And as most of our offices say, our front desk said, "Well, if you're more than 15 minutes late, you've missed your appointment."
Hmm.
So to this mom in this condition, in this situation, she knows she has to make it there. So she gets her kids off the bus and they run to our office, and her daughter has a seizure and she's, by herself. So she leaves her daughter outside on a bench. I mean, it makes perfect sense. But what I gained from this, what I learned from this is that I was really struggling with what trauma-informed care meant. And trauma-informed care means every touch point that you have with the patient, that you look at it with an understanding lens, with compassion. You don't know what's going on in that person's life, and you don't know how they're going to respond. And so to say to our patients, if you're not here in 15 minutes, for some people, they're like, "Okay, I'll be there, I promise, no big deal." But for others, this means a seizure disorder. This
Yeah.
this is
Yeah.
a life-threatening condition. So in my clinic, I've been in charge for all of our clinics of our trauma-informed practices, and we've introduced ACE screening, so screening for adverse childhood experiences among our patients. And that was just the very beginning of trauma-informed care. And so that's what I want to focus on going forward.
So tell us, in terms of ACE screening, trauma informed care, what would that look like in the exam room?
Yeah. So trauma-informed care, it starts in the front office. It starts when you make an appointment.
Okay.
So one of the things that we have been doing and we're working on now is scripting for our front office. So they're giving the same message to every patient. And we're really evaluating with, you know, what level are we speaking to our patients? You got to speak to them with a third grade level, make sure they know what you're saying, make sure you have translators available. And then your signage in your office, that's part of a trauma focused office. And then in our daily practice, we do offer behavioral health. We have a grant to have community health workers in some of our offices to help as health navigators. And I think if we had had one in our office, this mother might have felt like she had a person she could talk to and say, "Hey, I don't have insurance for my daughter. Can you help me?" That might have helped her on her journey. And then we're screening at well visits for adverse childhood experiences. We screen mothers and fathers and other caregivers at the 6-month visit.
Hmm.
So we're asking parents, what has happened to you that you think can affect your parenting? And what we found is that we don't have to do any intervention whatsoever. When a parent knows that we care, that's actually therapeutic enough. And then we're screening for children's own adverse childhood experiences at their well visits.
Now, has this been a big change from what you previously done? Is this normally done in a lot of pediatricians' offices?
This is a big change for all of us. And that's, why I wanted to get this out there. And I have a couple of other articles that I've written with you, trying to explain what we're doing and the challenges we've met in introducing screening for adverse childhood experiences. No, this is brand new. I don't think anybody has any experience with it. So that might be my takeaway message is nobody knows how to do this. So just start, just try. It's better than what you were doing.
Now, how did you learn about this? Is this typical in a lot of pediatricians' training in terms of trauma informed care? Is this something that you had to take classes for or learn from a website? How did you learn how to do this?
That's a great question. I haven't been in training in a while, so I hope that it's part of training now. I first learned about it by going to a conference, and so you want to look for those specialty talks at the conferences you go to. And I went to one on social determinants of health probably 15 years ago, and that's sort of what opened my eyes to the concept that our health is very much associated with what has happened to us and what our environment is like.
So you mentioned how anecdotes are so important. So tell us a success story. Is there a success story that you can share with my audience in terms of how this trauma-informed approach has moved the needle in one of your patients or patients' families?
It's been really helpful for the clinicians, I think, in terms of especially those frustrating diagnoses. So when you ask me that question, the first person that comes to mind is there was an 18-year-old girl who I saw in clinic, and she came in for anxiety and depression for an evaluation. And we are routinely doing the PEARLs, the pediatric ACEs and related life event screener, at our behavioral health visits. And this is a girl who's been in our clinic for probably since birth, actually. And her Pearl score, it's out of 17. She scored 14 out of 17. And so I stopped and I said,
So what does that mean? 14 out of 17? Is that
it's a really high score.
okay?
Yeah. Yeah. So in adults, we use the ACE screen and it's scored out of 10. And the science tells us that if you have a score of 4 or higher, that's very closely associated with a lot of long-term health effects, including substance use, depression, anxiety, hypertension, stroke, asthma, a lot of those things. So in kids, we do still consider a screen positive if they score more than 4. And as an aside, we actually often will raise our eyebrows with a score of 1 because that means you should at least bring it up and talk to them. And a lot of people underreport. So this girl scored a 14. And so I stopped and I said, you've had a lot of bad things happen to you. Do you think that this is affecting your mental health now? And it was the first time she had ever talked about any of these things with anyone. And it was 100% related. And what's interesting is that the data shows that when you treat anxiety or depression in a person who it's caused by trauma, their symptoms are caused by trauma, that we find that SSRIs don't work. And so it's a really important piece of the puzzle to know because they need trauma-based care. They need trauma-based therapy, trauma-focused CBT or cognitive behavioral therapy is the right choice for that. And I could give her Prozac forever and it would make no difference in her life. So she felt, I think, very healed just by the fact that she could tell me that. And when I went back to her pediatrician who had referred her to me and told her what had happened, she was like, I had no idea. So all those years that she came in for headaches and stomach aches, and I couldn't find a reason, it was from what was happening to her. It wasn't a primary pathology.
So once you uncover a high score or any score at all, you mentioned, things like CBD therapy. Tell me about the next steps. Like, what do you normally do in terms of addressing this?
So opening a conversation is the most therapeutic thing you can do. I mean, most people feel, especially with their pediatricians, but with their doctors, they feel like it's a trusted person and they're an authority in the patient's eyes. And to have one of us look into a patient's eyes and say, I care about what happened to you, that tends to often be all they need. We expected as an organization when we were going to start a screening, we, as I'm sure most of your audience feels like, oh God, I cannot open this can of worms because what am I going to do with these patients when they tell me all their problems? So we planned for that and we had lists of resources. People need surprising things. They need legal resources for immigration issues or divorce issues or having mold mitigated in their homes. I mean, those are the kinds of things like we don't know how to help with that.
Yeah.
So we did try to put together lists and it's turned out we really haven't needed them as we expected we would. The other thing we did, we partnered with a community organization that we can refer patients to who have high scores. So what we're doing now is we have a fax that you can automatically send from within Epic electronically. So within our EHR, it's like a letter and you only have to fill in 2 fields and then it automatically gets faxed to this organization and they proactively call our patients who have high scores. So most communities do have an organization that you can have a partnership with and they can provide the support. So that's an option for a lot of people. But what we have found is that all they really need is us. And if you're too busy, you can always have them come back,
And as you said before, simply asking the questions have tremendous benefit.
Exactly. Yeah. Yep.
We're talking to Wendy Hunter. She is a pediatrician. Her Kevin MD article is titled How a Teenager with Seizures Became the Face of Trauma-Informed Care. So Wendy, for those pediatrician and primary care offices who want to incorporate more trauma-informed care, more screening in their offices, where do you suggest that they start?
There's a great website called ACEs Aware, and that can be really helpful. I think that is a California website, but I think that our state probably is leading the efforts on being organized about this. So that's a good resource. It's got a whole clearinghouse of articles and a toolkit on how to do this. The first step is to have buy-in from your organization. So from your leadership, they need to believe that this is important. And that's the first step in the guidebook.
And did you have any issues with your leadership when you wanted to incorporate this?
Well, for us, it came top down. So
Sure.
that was really fortunate. Yeah. And that's where it came from. Plus, in California, there's money behind this. We get reimbursed for doing our Pearl screens from insurance. It's challenging, and that's been a lot of work to make those contracts, because a lot of the insurance companies include this in their group fund, but on a lot of them, we do get paid individually.
And my final question, Wendy, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
Really, it's just don't be afraid to try this. You can literally print out the ACE screen or the Pearl screen free online and just have them on your desk. And if you have a patient who is just coming in with chronic pain issues, you just can't find anything wrong with them, this is a really good approach. Give them a PHQ, screen them for depression with that tool, and an anxiety screener and the ACEs. And you're going to open a conversation that really leads to a better diagnostic evaluation.
Wendy, thank you so much for sharing your story, time, and insight. Thanks again for coming on the show.
Thanks, Kevin.